So prostate cancer is a really wide spectrum of lots of different things.
Let's be honest, the stakes are really high.
Do you say radiation and people think of Chernobyl, but actually radiation saves lives.
This is a podcast sharing conversations around radiotherapy, where you'll hear from world-renowned clinicians who are changing the game in oncology.
Well, thank you very much for having me on the podcast. So my name is Alison Tree. I'm a consultant clinical oncologist at the Royal Marsden NHS Foundation Trust in London, and also honorary reader at the Institute of Cancer Research. And it's also my pleasure to be part of the MR-linac consortium, currently serving as the chair of the steering committee.
So much that you've done so far in your career. Can I just ask you, did you always want to be a doctor?
Mostly. So I had a few bone problems, hip problems when I was a child. So I spent a lot of my childhood in and out of hospital. So I guess the medical profession were one of the first that I interacted with. And back in those days, girls were nurses and boys were doctors. So initially I thought I wanted to be a nurse, but then thankfully we're coming some way towards equality now, and I realised that I could be a doctor. And so that was my preferred option right up until my A-levels, when I had a little wobble, thought I might want to be a physicist, funnily enough, where I've ended up. But thankfully, just at the last minute, switched around and went back to medicine for university.
And can I ask you about being a clinical oncologist? Because that's sort of handling two disciplines.
It's not unique. There are other countries in the world, but there aren't many that combine what in the US is called radiation oncology, so using radiotherapy to help treat cancer, and also medical oncology, using drugs to treat cancer. But in the UK and a few other countries worldwide, we have this combined profession of clinical oncology, where we are trained in both sides of the oncology spectrum. And I like that. I think that's a really positive thing for patients, because it means that you have one doctor that can look after your radiotherapy treatments and also your drug treatments, and you don't need to be passed forward and back between different doctors.
So I would agree that that would be good for patients. Do you think it gives you a different perspective as a doctor to be almost two parts of an MDT?
Yeah, I think so. So it enables you to be much more holistic in the way you see the patient's treatment, because you're not just focused on the radiation, you're focused on the whole patient's life and how best to control their cancer, not just with radiation, but with drugs as well. So I think it's really good for the patients and really good for the doctors, because it keeps you focused on both sides of the coin, if you like.
How did you land on oncology?
For most of the first few years that you're a doctor, you're on the wards, you're in A&E, you're doing the kind of acute medicine bit where people are very unwell, you make them a bit better and then they go home. But I think I was frustrated with the fact that you don't really get to know your patients that well, because you're just sort of patching them up and getting them out of hospital. And so I thought I'll just try oncology and see if this suits me better. And so I went to do a 6-month job at the Royal Marsden, and I totally loved it. I loved the fact that you got to know your patients, those patients coming in repeatedly over that 6 months for their drug treatment or whatever. And the patient was your responsibility, if you like, whether they were in or out of hospital. So I really sort of enjoyed that more. I find that more fulfilling, and decided I was going to stay in oncology.
Why did you choose prostate as one of the indications that you wanted to focus on?
Yeah, I get asked that a lot, obviously, I think, as a woman, because there aren't many female GU oncologists. But I think what really made me pick it, one of my early jobs was with a professor called David Dernley, who you may have heard of. So David ran some of the pivotal trials in prostate radiotherapy. And I was lucky enough to work with him quite early in my career. And what I liked was that if I said to him, why do we treat in this way, with this dose or with this margin, the answer would never be, that's just the way we've always done it. The answer would always be, we did a clinical trial, we tested this against this, and these patients did better, and so therefore this is the right answer. And I like that precision and the data-driven, evidence-driven way in which prostate oncology works and still works today. So that's how I got attracted to prostate oncology.
Did you ever consider a completely different type of job?
No, I guess so. The physics I wanted to do was astrophysics, so that would have been obviously totally different. So, I did all my open days for physics with astrophysics, which is a fascinating topic, really interesting. But I couldn't really work out what job I wanted to do with that degree, and so that's what sort of brought me back to medicine, I think.
Do you know what, I was thinking about this morning, and I was thinking, I wonder if I could almost guess what you might say. And then the thing that I came up with was an archaeologist. Because
interesting.
Yeah, I can kind of imagine you just very methodically and tenaciously going after some discovery that everyone else is like, no, they're never going to find that, or they're never going to do that.
I've never thought about archaeology. The one thing I did think in retrospect, looking back now, I would have been quite a good party planner, or some kind of planner, because I like detail and organisation, and medicine's not always like that. So maybe I missed my calling as a party planner.
kind of on the same topic, but not. I think it's fair to say a lot of people admire you. And, you know, when I mentioned you on the podcast, everyone's like, oh, I love Alison Tree. And I don't know how she does everything that she does. Do you have something that you do that takes you away from work? So I imagine that you're on a lot, even when you're not, you know, in the hospital.
Yeah, I definitely don't get this right, so I should not be any role models, because I think it's impossible to do it all, and you have to make choices about what's important in life. What I've tried to do when the boys were little, I've got 3 boys, is to work part-time. So I was lucky enough to be in a country and a system that allowed me to work 3 days a week. So that was a big priority. So my kind of off switch for work was actually a harder job at home, but at least it gives some balance to life. I just try and keep healthy, do some exercise, I go to church, try and chill out with my husband now and again, and just do things that take me away from work, because I love my work. Otherwise I would be completely absorbed in it and doing it all the time. So it is important to put some boundaries in, and I'm really terrible at doing that, but I'm trying to be better.
Is there a way, or how would you kind of advertise radiation therapy to a radiographer or a radonc, actually, or a physicist?
Well, I think for the therapeutic radiographers, for me, it would be an easy decision, because actually you're part of curing that patient from cancer. And I know that the diagnostics are too, in the way that they help image the patient, but the therapeutic radiographers I work with a fantastic team who are part of that patient's care and see the patient daily. They support them through their treatment. And so I think it's a very patient-focused, sort of hands-on type profession that I think loads of people would like, but I think too few people know about it. It's not something that's widely publicised as a career option at school, for example. And the same with medical physics, a little bit stepped back sometimes from the patient, but I think if a lot of physicists knew that they could really impact how you cure cancer, then that would be quite motivating. And then in terms of oncologists, you're right, we're vastly short of them in the UK and in many other countries around the world. And I think it is about getting in there early, talking to medical students and junior doctors, because they will have no exposure at all, most of them, to radiation oncology or clinical oncology. And so I think it's finding ways to educate and advocate and tell people. I think if people are here, then they'd want to do that as a profession. I've certainly loved it.
Can I ask you to explain prostate cancer in the most simple terms that you can?
Right, that's quite a difficult question, but I'm going to take a swing at it, if I may. No, it's fine. So prostate cancer is a really wide spectrum of lots of different things. So we'll take it from the nicest end, if you like. So we know that most men, in fact, as they get older, will have some kind of prostate cancer if you were to go looking hard enough. And obviously we don't always go looking, because we know that much of prostate cancer is actually almost a normal variant of aging, and a lot of it doesn't ever need treatment. So sometimes when we find prostate cancer, we simply tell that man to keep an eye on it. We'll monitor them with scans and blood tests. And at the other end of the spectrum, you've got a very aggressive, advanced kind of prostate cancer where it's already spread to different areas and is sadly incurable, and some of those men will die of their cancer. But most of the men are up the good end of the spectrum when we find their cancer, and that means that the cancer is just in the prostate region, and with appropriate treatment we're likely to be able to cure it. So if you think of it as a wide range of different diseases, then that's a better way to think of it than just thinking of it as one thing.
Is there a question that you get asked sort of the most often, something that comes up a lot?
I think the most common thing I get asked, or sometimes I have to encourage them to ask it, is how likely am I to be cured? That's, if you or I were told we've got cancer, that's the first question you want to know. Am I going to get rid of this? And then the second question is, what are the side effects of that treatment I need to get cured? But I think what's really important when you see someone for the first time is to make sure they understand where they are. And for most of those men, that actually cure is on the table, and it's the expectation that we will cure them over time. So it's when I talk to our junior doctors, we go through some scenarios, what percentage of men in this scenario will be cured, because I think that's our most important job, is to convey that information to the man in front of you specific to their cancer.
And as you say, you sort of mentioned side effects. There's sort of no magic treatment at the moment that doesn't have any side effects at all.
Yeah, although occasionally I tongue-in-cheek called radiotherapy magic rays, because that is people don't have a concept of what radiation is. So, but you're right, all treatments have potential side effects, and so our job is to really find out from the man what's their priority. Is it cancer cure? Is it sexual function? Is it bowels? Is it waterworks? What is the thing that they most want to avoid? And that helps then you to direct your consultation to explain the most useful options for that man.
If I try and put myself in the shoes of a man who's just been diagnosed with prostate cancer, and how enormously stressful that must be, and all getting the appointments, and then going to the clinic for the first time and having you on the other side of that door, I honestly can't think of anyone better for them to sort of speak to. And if not,
very sweet.
if not
Thank
least,
you.
Have them think everything's going to be okay. Have this sort of sense of like, this person's really going to help me find the right, the next move or the path forward. So, yeah, that's why I
very
wanted
kind of you to say.
Just wanted to say that. I sort of see that there is sometimes a bit of a negative perception around radiotherapy. If someone doesn't, isn't exposed to it or doesn't have a relative who maybe has had treatment, what do you think their perception is of radiotherapy?
I think it's a huge problem. You've hit the nail on the head, and it comes to the whole public as well as the people that get into the clinic, that actually you say radiation and people think of Chernobyl and bad things, but actually radiation saves lives. We've got great evidence of that, and it's involved in about half of cancer cures. And so we need to keep banging that drum and educating people so that they do make the right choice for them, because a lot of people, everyone knows what surgery is, right? You cut it out and it's gone, in inverted commas. And so a lot of men, I think, end up going down the surgical route because they don't understand the benefits of the other option. And so it's really important that men are offered a chance to speak to an oncologist about the non-surgical options, which actually may be better for some of them.
Yeah, but I really wanted to ask you about something to do with prostate patients, because I'm generalising probably when I say this, but I think maybe women who are of a similar age that sort of men are when they most often get prostate cancer are a little bit more used to going to the doctor and, maybe talking about things like fertility and sexual health. But actually, for a lot of men who are diagnosed with prostate cancer, they maybe have to think about how their quality of life and their sexual function, for example, might be affected by the treatment. Is that something that you experience with? Or, is there a certain way that you tackle that, or could you share?
Regardless of what kind of treatment you pick, there is a risk to sexual function with prostate cancer treatment, and that the number of men affected varies widely between surgery and radiotherapy, but all treatments have risks, as we've said already. And I think it is quite hard to talk about sexual function with someone you've just met a few minutes ago, and especially as a woman, I think that can be difficult. But on the other hand, sometimes I think it makes it easier than talking to another man, so everyone's different. But it's really important that we bring it up in terms of the consultation and talk to the man about whether this is an important part of their life, that it's an important part of their deciding on which treatment to go for, and also remembering to ask about it after the treatment, and just encouraging them to pursue recovery from sexual function afterwards, if that's something that's important to them. Because I think sometimes we forget to ask. We ask about bowels, we ask about bladder, and we must really importantly ask about sexual function as well, because if it is affected, often it can be improved significantly with very easy things like tablets, for example, and it is part of life, so it's important to mention it.
So when we sort of talk about SBRT, can you explain what it means in terms of radiotherapy?
Yeah, so principally, when we started using radiotherapy decades ago, it was always given a daily treatment, usually over 6, 7 or 8 weeks, so giving a tiny little bit of radiation each day called a fraction. And what we found, particularly with prostate cancer, but now increasingly with other cancers, is that you can cure the cancer better if you give a bigger dose, a bigger dollop of radiation on just a few days. And that's what SBRT helps you do. It means giving a big dose of radiation just a few times, maybe 3 or 5 times, depending on what you're treating. And you have to deliver that very precisely, because you're giving a big dose each day, so it really has to hit the spot. That's essentially what SBRT is.
Thank you, because I do think, and I was talking about this a bit earlier this morning with some of the team here, it is kind of one of the first things you're taught about in radiotherapy is a sort of fundamental, is that you have to fractionate and space out the treatments so that at a basic level, so that your healthy tissue has a chance to recover and your cancer cells are able to get the dose they need. So I do think it could be a little bit confusing if you're not, fully in the field to understand that suddenly we can do that in less treatments.
And I think the more research we do, the more we're understanding that what we were all told, and I was taught exactly the same as you, that you fractionate, you give lots of treatments to spare healthy tissues, but that doesn't work for all situations. And we're now much better at picking out the situations like prostate cancer, where we can shorten the treatment and then you can cure the cancer and the man can get back to normal life a lot quicker. So that's a bonus.
Do patients ever come to you and ask about specific types of technology, or it's something they've
Yeah.
Googled maybe and
Yeah.
seen? Or...
They do, obviously, as we all do with our health, we Google things, and
Yeah,
I do it too.
I do as
So
well.
I often have people, back in the old days, it was clippings from the Daily Mail, but now it's normally a
Oh
printout
God.
from Google. So I have patients come and ask specifically about the MR-linac or the CyberKnife, or ask about one of the trials that we've run and ask if they can have that treatment. And obviously, protons always gets a lot of Google hits, so I often get patients asking about protons as well.
And how are patients responding to the option of the MR-linac in particular?
Not everyone knows about the MR-linac before we talk to them about it in clinic, but there are certainly patients who come in asking for it specifically. Generally, when I talk to men about the MR-linac, I would say you don't need to have the gold seeds inserted. Those gold seeds we use to target the radiotherapy. And for many men, that's a kind of deal breaker. They definitely want the MR-linac after that, because a lot of men want to avoid having that other extra invasive procedure. So it's been very popular in general.
I want to ask you about the HERMES trial, but I think it's fair to say that there's been a big build-up or lead-up to the HERMES trial. There's been years of work that's happened.
Yeah.
You mentioned the PACE trial. Can you talk a little bit about that? Because it hasn't been a
So
short road.
It has not, and you're right. But it probably predates PACE, because the trial before that was called CHIP. So that's where we've made that first leap, where we went from giving 7.5 weeks of daily treatment down to 4 weeks of daily treatment. So that's now changed the standard of care across the world for localized prostate cancer. There's no evidence that treating in more than 4 weeks is of benefit. But PACE built on that. So PACE said if you can go from 7.5 weeks down to 4 weeks of treatment, then why can't we push it further? Can we go down to 5 days? And that's what we've been testing in all of the PACE trials. There's now 4 PACE trial babies, as they were. They keep coming along. And PACE fundamentally asked the question whether we can go down from 4 weeks down to 5 days. And as you probably saw, we've recently published the PACE-B 5-year results and showed that a very high number of men, 96% of men, have no evidence of cancer 5 years after treatment in just 5 days. And it was about the same for the 20 treatments as well, but certainly no benefit from making the treatment any longer than 5 days in terms of cancer control. The bit I haven't mentioned yet is that there are some differences in the side effects that we see. So although the SBRT, the shorter treatment, is just as good at curing, if not better, there is a penalty to be paid for about 6% of men. They have more bladder side effects, particularly those men who have a sort of weak bladder, if you like, at the start. So I think there's an ongoing discussion in the community, and it should be with the patients as well, about whether that alters how we implement those results. Do we give SBRT to everyone, or do we try and select out the men who we think are going to do fine? And maybe for the men who've got bladder problems at the start, give them the 20 treatments after all. So I think that process is ongoing. There's a sort of academic debate going on amongst oncologists about how we position this treatment going forward. But certainly it is a big moment in that it's the first time that we've shown the cure rates are at least as good for 5 treatments. So that's the kind of landmark, and now we have to work out how to implement that.
I think the sort of different centres, both nationally as well as internationally, will, quite rightly be wary of changing. It's something that they've done for a long time, because let's be honest, the stakes are really high. I guess that takes us on to the technology a little more as well, because you thinking about giving those higher doses and the side effects and looking towards those 5-year outcomes, that's you have to be a little bit brave to be someone who's trailblazing that, I think, or you have to be very sort of confident in how you're delivering that treatment. Yeah,
absolutely. And it certainly applies for 5 fractions. And coming on to HERMES, that's why I was indeed, a bit hesitant about HERMES, because we knew this was the next obvious question. Can you go down from 5 days to just 2 days? But until we had the Unity, I didn't have the technology that I felt really confident to test that question on. So that's why the machine was so important to the next phase of our research, because suddenly I can see the prostate, the edge of the prostate, in real time as I'm delivering the dose. And so I felt much more confident to give these really high doses per day just twice. And HERMES is the result of that.
There was like one moment maybe, and maybe you've just alluded to it, I don't know, if you looked at the images for the first time, a bit of a light bulb moment, or if it just sort of happened organically more through your work with a consortium, for example?
Yeah, I think it had been percolating in a few people's minds for a while. And indeed, we're not the only people doing a 2-fraction trial. There's one going on in New York and one going on in Canada as well, and another one in Israel. But I think we started the MR-linac treatments in 2018, and so I guess there probably was a moment sometime when I was sitting there watching the treatment happening, thinking, actually, now we can do this. We can actually test this question. I think the nice thing for me was that because it was quite intense, that first period of using the Unity. We were all learning together.
Yeah.
So I had a lot more day-to-day interaction with the therapy radiographers and also the physicists. So we all kind of learned together. So it was quite a team bonding experience. But also now we've moved into a phase of empowering the radiographers to do additional tasks. They can contour the prostate as well as I can now because they've been watching them for so long. So it's just a nice way of developing everyone's competencies and confidences to do more for the patient each day.
And if you could just explain a little bit more about HERMES.
Yeah, so HERMES is a small trial. It only ran at the Royal Marsden, but it's a randomised trial. So this means that all the men that went into the trial, they volunteered, and they all had similar types of cancers, the kind of cancers we would expect to cure, all prostate cancer. And half of them got the 5 treatments that we've been talking about with SBRT, like we did in the PACE trial. And the other half got just 2 treatments of radiotherapy. So this was the novel part. It had never been done in the UK before. So we had to take a deep breath because it's obviously difficult doing something new, but the patients were amazing, and the men that volunteered were really on board, and they were really enthusiastic about the concept of the trial. But we've finished the trial now. We recruited 46 men who volunteered.
The HERMES trial, speedy delivery of prostate radiotherapy, a trial of cutting-edge short-course radiotherapy for prostate cancer. The team at the Royal Marsden Hospital are trying to make prostate radiotherapy better. And they know for certain prostate patients, 5 treatments of stereotactic radiotherapy, or SBRT, works. So they are testing if fewer, higher doses of treatment could work too, and with less side effects. Men who are eligible for HERMES are those who have newly diagnosed localized prostate cancer, which means that it hasn't spread. HERMES is a phase 2 single institution randomized trial. This means that a computer will randomly select one of 2 arms that each patient participating goes on. So that's either 5 SBRT treatments over 10 days, known as hypofractionated, or 2 SBRT treatments over 8 days, known as ultra hypofractionated treatment. Stereotactic radiotherapy, or SBRT, is an accurate way to deliver a high dose of radiotherapy and a smaller number of treatments. In order to deliver SBRT, beams are very accurately directed from different positions around the body. In order to safely deliver high doses in less sessions, SBRT needs to be super accurate. Therefore, patients on the HERMES trial are treated on the MR-linac with MR-guided daily adaptive radiotherapy. Treatment is adapted or tweaked based on high-field MR images before treatment is delivered, and live MR images are seen throughout the entire treatment session. This means the prostate can be more precisely targeted, and there is no extra dose given, unlike CT scans. Patients who are randomized into the 2-fraction arm will also receive an integrated boost, which is an additional boost of higher dose to what is known by clinicians as the dominant intraprostatic lesion. This lesion inside the prostate can be seen using MR images, and studies have shown that if a patient has a local recurrence, which means the cancer returning, then that occurs here in 89 to 100% of patients. The side effects and outcomes of the HERMES trial are currently immature, but they may be very influential in determining the future direction of prostate radiotherapy. What could possibly be next after that?
Yeah, well, I'll tell you what we're not going to do next, which is the obvious thing that people listening might be saying, well, surely you go down to 1 treatment now. But unfortunately, that would have made a lovely story, and I could have made great talks about that. But sadly, previous people have checked 1 fraction, just giving 1 big dose of radiation, seeing if that cures cancer. And the answer is it doesn't seem to do a very good job. So we don't want to go there. We don't want to compromise any cure rates. So we'll stick with 2 as the minimum for now. But we are increasingly aware, especially with the Unity, where we can see the actual tumour, not just the whole prostate, but where the actual tumour is within the prostate. And what we've always done forever is give the whole prostate the whole dose, but that doesn't make a lot of sense any longer because we can now see where most of the cancer is. So why don't we give more dose to the cancer and less dose, still some dose to get rid of any few cells that might be floating around, but a lower dose to the rest of the prostate. So really focusing the radiation where it's needed. And that's going on in a couple of trials. So Destination, we've just completed doing that kind of approach in 5 treatments, and we're about to start a trial supported by Elekta called Destination 2, where we're giving just 2 treatments to either the whole prostate or just focusing on the cancer to try and see if we can tell which of those 2 approaches is better.
And the Destination 2 and actually one that you just mentioned are part of something in the consortium or the work that the consortium does.
So Destination 1 sort of organically sprang out of the consortium in the sense that we just had 3 individual sites, us, the Royal Marsden, NKI and Sunnybrook in Canada, who all sort of had the same sort of thinking along these lines. And so we thought we would join forces, all run the same trial essentially, and then pool the data at the end to try and increase the knowledge that we're gaining together. So it's a nice example of collaboration across the MR-linac consortium.
You're currently the chair of the MR-linac consortium.
I am, yeah.
What's that like as a role? You've got many roles already, that, as you know, an additional role in your life. What has that brought to you?
It's been really, I've loved it actually so far, because it's brought something completely new. This is leading a slightly sort of a global consortium. So there's a lot of partners now. We're nearly up to 100 different hospitals globally that have a Unity and are part of the consortium. And so it's quite a big group of people with lots of different ideas and needs and what they want the consortium to be. So it's been a bit of a challenge for me to think through how to best serve everyone with the limited resources we have available, and still keep everyone engaged, because we have 2 roles in the consortium. One is to help educate and to share knowledge across all of the sites, but particularly focus on the new sites who are just starting their Unity journey. But also, and this is obviously what I'm quite passionate about, is the research that we can do together. And so it's trying to keep together the research side of the consortium as well, and just put people in contact who've got similar research interests to kind of make the most of those connections across the world. Because the last thing we want to do is be solving the same science problems in several different continents. Why don't we just share knowledge and do it all together?
The final thing I wanted to ask you related to the consortium is momentum. Because I think this can be a little bit confusing as well, and it's a good thing to appreciate, exactly what momentum is. If you could just say a few words about that, or how you see the value of momentum as well.
So momentum is a sort of a part of the consortium. It's an observational trial, so men and women, so people with all different types of cancer, volunteer to have their data put into momentum. They're in control of what data goes in, but in theory, for every person within the momentum centres treated on a Unity, you could have all of their data. That could include the scans, the radiotherapy plans, how they're feeling, their clinical data, and how they do over the years. So it's an unrivaled repository really of data from which I hope we'll be able to learn lots of fantastic things, new things about cancer of all different types. And it's led from the team in the Netherlands, but there are many global sites now participating and putting data in. And we've already seen some fantastic outputs, some papers in scientific journals looking at how well in general people are doing after Unity treatment. So that couldn't have happened without momentum, which has been very much supported by Elekta.
That's great. And I think also sometimes people forget that behind every piece of data is a patient who's quite generously sort of handing that over. Do you think they have a sense that they're contributing to something bigger as well? Yeah,
I hope so. And I think what we see, because we try and offer research to as many people as possible at the Royal Marsden, it's part of our ethos. And I think it's a way of giving that person back a little bit of control in a situation that can be really worrying and scary, having cancer. But they have an opportunity, if they want to, and it's all voluntary, to participate in giving their anonymised data over to be used for research. And for some, that's a really positive way of giving back to their family and their children maybe who may benefit from that research.
I've seen you do a presentation before where you said, and I'm sorry if I misquote you, but you said you didn't want to retire doing radiotherapy in the same way that it's done today. Now, I feel like you've already achieved that, but you're not allowed to retire, obviously. But
I will one day for sure.
Do you feel like you're kind of there, or do you have this sense of like, no, I've still got a lot to do, or how do you feel about it?
I've still got loads of ideas about things I want to test, but you're right, at some point I will want to retire. But I think more importantly, what I want to see is the generation below me coming through and having their own ideas. I think I'm moving into that phase of my life now where I'm trying to see who I can encourage and grow up to deliver the next lot of trials, because none of us are here forever, but we want to make sure that we leave the field in a good position so that the next tranche of trials can come through, and there'll be some great ideas coming through. Look how far we've come in 20 years. It's amazing, just in prostate cancer. So lots of optimism for the future.
But we're a long way off. We're a long way off that yet. So.
Thanks.
We don't need to think about that. Okay, Alison, well, thank you. It's been such a treat to have you on, and thank you for your generosity and how you've answered the questions as well. It's been great.
Thank you for having me on. Yeah, all the best with the podcast.
If you enjoyed the conversation today, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.